A very warm welcome, ladies and gentlemen, distinguished panelists, and my esteemed viewers. We welcome you to this insightful session in celebration of Nutrition Week. I am Dr. Nishant Sharma from Voice of Healthcare, and I'm honored to be the moderator for this enriching session. Voice of Healthcare, in collaboration with Esperer Nutrition, is here to mark the occasion of National Nutrition Week, which spans from 1st to 7th of September, as we recognize the paramount importance of nutrition, particularly in the context of cancer care. Cancer, a complex and a challenging journey, not only impacts the body's physical well being, but also has a profound implication for nutrition and the overall quality of life. Today, we have assembled a panel of distinguished experts, each bringing a unique perspective to the table. We have with us renowned medical oncologists Dr. Purvish Parikh and Dr. M.V. Chandrakant, who have dedicated their careers to understanding and treating cancer. Joining them, we have Ms. Naaznin Husein, a seasoned dietitian and nutritionist whose practical insights have a tangible impact on patients' life. Our panel today will delve basically into three phases of cancer care, which will be preconditioning of nutrition, complementing the mainstream treatment through nutrition, and restoring the homeostasis post oncology treatment. These phases represent the intricate dance between the medical science and the nutritional support, where collaboration amongst medical professionals and the caregivers play a very important role in the essential patient outcome. And these phases also set the foundation for an effective treatment, and we will explore how well tailored nutritional strategies can enhance the patient's readiness for a therapy, can enhance their treatment taking ability. And as we navigate through these discussions, I encourage my esteemed panelists to share their expertise, their insights, and their experiences. And I also engage all my viewers to share their questions and have this to be a two-way knowledge exchange. Together, let's embark this journey of understanding the pivotal role that nutrition plays in cancer. And we will try to aim illuminating all the new perspective, challenge the misconceptions, and ultimately contribute to a very holistic well-being of cancer patients and their caregivers. Without further ado, I'd like for each one of the panelists to give a small set of introduction. I'll start with Dr. Purvish. Good evening, Dr. Purvish. We welcome you to the panel. A few words of self-introduction, please.
Thank you very much, Dr. Nishant. It's a pleasure to be part of this panel on the Week for Nutritional Awareness. I am a medical oncologist and clinical hematologist. I was earlier professor and head of medical oncology at Tata Memorial Hospital in Mumbai, and now I'm professor and head of clinical hematology at Mahatma Gandhi University of Medical Sciences and Technology. Nutrition has been an important passion for me, and therefore I was instrumental with Dr. M.V. Chandrakant in setting up the Asian Nutrition Society. And we hope to take our work forward so that our patients get the optimal benefit. Thank you.
Right, sir. We look forward. Thank you. Thank you for your introduction. Moving over to Dr. Chandrakant, a few words of your esteemed introduction, sir.
Yeah, thanks, Dr. Nishant. Thanks for having me here. So I'm Dr. M.V. Chandrakant. So I'm a medical oncologist. I'm an academic head in Narayana Hospital, Kolkata. So Dr. Purvish has been an inspiration in multiple aspects, and he has helped us in coordinating, in understanding between dietitians and doctors. So nutrition has been a passion. It is a passion because patients perceive nutrition and diet as the most important thing, much more important than any treatment. Therefore, it has to be a passion for all of us. Thank you. Thanks for having me again.
Yes, sir. We are. It's a pleasure to have you in our panel. Moving over to Miss Nazneen, a few words of your self introduction, please. Thank you.
Hello everyone, good evening. My name is Nazneen. I've been a clinical nutritionist. I'm also the nutritionist to the Indian Navy and the Armed Forces, and have spent many years counseling patients, talking to their caregivers, and translating all the complex medical science into practical guidelines what patients can actually convert and eat it at home. So I think uh, there are with cancer there are plenty of challenges, and I help them to resolve that at home levels and make sure that how all these guidelines are followed by patients and caregivers. Thank you.
Right. Thank you, Nazneen, for the lovely introduction. So I hope all the panelists are now ready. I am going to start this discussion. I'm going to shoot questions at each one of you in a systematic manner, and let's see how well we are able to take this conversation and engage with our audience. So my first question will be for Dr. Purvish. Let's talk about the preconditioning nutrition. So, could you please explain the significance of preconditioning nutrition in oncology cases before initiating any kind of treatment? And are there any key nutritional considerations in this phase that a patient or a caregiver recently or should take care of? Over to you, sir.
So India is a vast country with a large amount of variations across our ethnic population, across geographies, across their socio-economic background. So the 1.4 billion of Indians are a representation of the world actually. And while we are on the moon with Chandrayaan 3, we also belong to the low and middle income countries. So, nutritional deficiency is an inherent part for the majority of our population. And therefore, its assessment before the start of any disease directed therapy is extremely vital.
Mhm.
Now, there are two factors which us doctors don't understand and we need to pay attention to. The first and foremost is what is in the mind of the patient regarding the nutrition. Chandrakant already mentioned that we have to be cognizant of what their preferences are. We can't expect an Italy eating Bangalorean to have churma bati that we see in Rajasthan or
Mhm.
something else that is fish that is there in Odisha. So, Naaznin and Chandrakant and myself, we have been working on food equivalents to
Okay.
identify what is it that we can prescribe based on the specific background of the person and the needs of the patient. Now, we did a survey to identify what are the common questions that a patient has before the start of treatment. And it can be divided into three broad categories. One is
Okay.
a general question: can I eat this or can I eat that? Saying a specific item. So we might say, can I have chas or can I eat chocolates or can I, have ice cream? So that is the first category of questions where they are asking specifically on a single item whether they can eat or not. The second type of questions is where they ask, what can I eat or what should I not eat? You know,
Mhm.
this is also a general category of questions, but there is no specific target that the patient or family member is looking at. They are asking a
Mhm.
general question. And then the third category is the most interesting because here they have a specific question based on their background and the disease that they have.
Mhm.
So one person will ask, I am a cancer patient, but I have only one kidney. So under those circumstances, when I have a comorbidity, what is the food item that should I eat? Another question is that since I am a patient of acute myeloid leukemia, what is it that will prevent me from vomiting while the chemotherapy is going on? So there are three categories of questions that the patients have. This is in general. Now,
Hmm.
various details of these categories also differ based on the age group of the patient.
Okay.
So, a teenager between the age of 13 and 19 will have a totally different question as opposed to a person who is an elderly person.
Correct.
And many times, the elderly persons are asking specific questions because they are used to a common way of eating, that habit that has been developed over the years, and they want specific answers regarding that habit. Whereas
Hmm.
the teenagers are more open, they have more questions. They, want to counter question when something is prohibited or something is interesting. So this is the sort of variations that we see. So even before assessing the nutrition and assessing what is the pre-treatment sort of nutritional
Hmm.
diet that we want to give, the first thing that we look at is the nutritional value of the patient.
I think we're missing on Dr. Purvish's internet a little.
Oh, I'm so sorry.
Yeah, yeah, yeah. You're back, sir. Please.
Yeah.
Yes.
So this is what I would say as a pre-evaluation before we get into the specifics of the nutrition. I will
Hmm.
stop here and then
Okay. Yes.
you can ask the questions of me.
So very, very rightly, the way you said that nutritional needs will depend very greatly on the type of cancer or let's say the treatment regime that an oncologist decides. My next question will be to Dr. Chandrakant about personalized nutritional plans. So let's say that every cancer case is unique and the nutritional needs will very greatly be based on the type of cancer, the extent of cancer, and the treatment regime. So, how do you, on a personal level, have worked with nutritionists to create a very personalized nutrition plan that align with each patient's, let's say, medical needs and the treatment goals that you've had in mind for them? Over to you, Dr. Chandrakant.
Yeah, so personalized nutrition is extremely important. You know, food is a taste of an individual. No two individuals can have a similar taste. Therefore, food has to be personalized.
Hmm.
So when a patient with cancer walks into my clinic, I ask him two questions. Number one, have you lost your weight? Number two, has your appetite reduced? So if the question to any of the two is yes, then this patient falls into a category of malnutrition. The moment
Okay.
there is malnutrition, we have various malnutrition screening parameters. We screen and we grade them to assess the severity of malnutrition, whether mild, whether it is moderate, whether it is severe. Now, once you have put them into the right box, now our nutritional plan will depend on how severe the malnutrition is. Let's say a patient has severe malnutrition, he needs admission, he needs IV nutrition and so on. Whereas if the patient has only mild malnutrition, then just a bit of dietary change and this would work. So now there are various flavors of protein powders the patients keep in hand, and some patients would need like apple, some patients would like meat. So we should have a brief discussion with the patient and the relatives as to what are his likings. As Professor Purvish was mentioning, that different categories of patients would need different diets. So for a vegetarian patient, if you want to have a high protein diet, then we can choose for him on paneer, soya, and so on. Similarly, if a patient who can eat non-vegetarian, then we can, of course, recommend him chicken, egg, and so on. So,
Right.
so we need to assess the severity of malnutrition.
Mhm.
What are the likes and dislikes of the patient? What flavor the patient likes? Very importantly, those patients on chemotherapy would love an orange flavor.
Hmm.
That flavor actually tastes well for our chemotherapy patients. So depending on all these, we sit one to one, and nutritionists and dietitians are really working very close with them. But at least we can have a coordination with dietitians as to what is the severity and what is the likeliness of the patient. And as an oncologist, what is my expectation? How soon this patient would need a recovery? So this are a few thoughts from my side. Thank
Right. So
you.
very, very nicely summed up, Dr. Chandrakant. Moving over to Miss Nazneen now, talking about the dietary strategies. Mr. Sen, could you elaborate on the dietary strategies that you feel can complement the mainstream cancer treatment, helping patients manage the side effects or also maintaining the overall well-being? And also, I would like you to bust some common misconceptions that you would have often faced in this context. Over to you.
Sure. Thank you, Dr. Nishant, for your question. So, like very well explained by Dr. Purvish and Dr. Chandrakant, that the personalization definitely is required. Okay. Now, when we're looking at strategies, there are so many challenges, right? Right from a nauseating person to somebody who's feeling extreme constipation, depending on which area, organ specific cancer, to diarrhea or intolerance to food. Sometimes you want to give the non-veg items as a high protein item, but they are not just able to tolerate because of the smell, and it becomes impossible. So even for considering all the cultural background, also we still have to make some shifts. Like a lot of people are unable to tolerate milk for some reason, so then you've got to look at, if it's a vegetarian patient and you're wanting to give him milk as a high protein source, he's not able to. So then we look at whey, we look at curd, we look at probiotics coming in pre-digested forms, so that we are able to move the meet the protein gap. Also look at other sources like a pea protein supplement, which
Mhm.
does not, the acceptability to the GI is much better. Other things, like we also have to integrate the recipes in their household thing. So if at
Mhm.
all, if they're having a juice and there's too much of nausea, we give them some amount of ginger, because ginger actually helps in reducing the nausea. So smaller tips, rather than changing the entire diet, modifying their diets in a way that they're able to kind of implement it to the best possible format, is something which we do. Other things which we look at is also the inflammatory factor. So we try and include some amount of anti-inflammatory foods like the nuts, the seeds. These may be new entries. Many a times people haven't eaten them. So it's slightly difficult to introduce those foods at that point of time. And so a lot of brainstorming needs to be done. Nuts and seeds again are expensive categories, so we have to look for the low cost recipes many a times for
Mhm.
patients. Millets is an anti-inflammatory food, and we are celebrating Nutrition Month. And
Mhm.
this time's Nutrition Month theme only is Suposhet Bharat. And I think Dr. Purvish spoke about malnutrition. So I think a lot of strategy building happens right from the first time the person comes in. Better hospitals, we are seeing the patient before the treatment starts, and that's a great time to catch the person, because if we do the prehabilitation, you're
Mhm.
building up so that during treatment and after treatment, the treatment is well received. I think there are a lot of policy makers also listening to the show, and sadly, nutrition is not given so much of an importance. um, if a person is well nourished, prehabilitated well, his
Mhm.
length of stay also, the treatment is well accepted, and the length of stay also reduces.
Mhm.
So when we do a lot of strategy in terms of nutrition, explaining to patients also on why early nutrition is important, because
Mhm.
at that point of time, they are only in a hurry to start treatment, and so
Right.
nobody is really wanting to understand why abhi khana hai. Most
Mhm.
of them will say अच्छा बाद में देख लेंगे.
Mhm. Mhm.
But busting that and making them understand why you need to start first, so that length of hospital stay, everything, surgery is better accepted. Those are some of the things which we greatly work on.
Right, right. So I think your effective point mentioning that it's also about the caregivers to those patients who are undergoing the
Yeah.
treatment. Building on that, my next question is going to be for Dr. Purvish. This is about caregivers and the patient's education. So, how do medical oncologists and practitioners such as yourself effectively try to educate the patient and their caregivers about the importance of proper nutrition before starting the treatment? And any specific strategies that you feel have shown you better compliance by the families? Over to you, sir.
Right. So this is also a very important issue. And communication cannot be the same for every individual. In fact, we've written a chapter in a book by Elsevier which
Mhm.
says that the patient's personality should dictate how we communicate with the patient. And there are 8 categories, and we have to cater to them. But the best way to communicate in each of them is to give a living example of somebody who is well known or well respected in society as it is. For
Mhm.
instance, Naaznin mentioned about inflammation and how we want to avoid that. Now, the best example that I give to vegetarian patients that it is possible to still be vegetarian and have adequate protein intake is by taking the example of Virat Kohli. He is a athlete par excellence. He is, at the helm of cricket for India, and cricket is, I think, the passion for most of us Indians. And earlier he was a non-vegetarian, but now he has become vegetarian. And he says that the reason for me to change was I wanted to maintain my muscle mass and strength, at the same time reduce the inflammatory effect of non-vegetarian food in my body. So
Okay.
we have to find out such examples from the real life, from people who are respected and popular, and which the patients can easily relate to. And once we make this connection and then, tell them what we want them to do, they are more open to understanding as well as following what we do. So this is a simple method that I use while communicating with patients. Back to you.
Right, sir. I think that obviously is a very correct way of communicating, because humans have the general tendency to relate and then feel a little more inclined towards accepting something when it becomes socially acceptable. So I think a very nicely summed up strategy. My next question will be for Dr. Chandrakant about monitoring the nutritional status. So this in this question, I'm talking about during the treatment phase. How do you assess and monitor a patient's nutritional status? And are there any specific indicators or markers that you particularly pay close attention to in order to adjust the treatment plan during the phase of the treatment? Over to you, Dr. Chandrakant.
Yeah. So as we discussed just before, it is not sufficient. I just make a diagnosis of malnutrition. So I made a diagnosis in the baseline, and then I categorize this patient into what is the severity of malnutrition, and then I did a nutritional intervention. Now I need to periodically assess, is there any improvement in the nutritional parameters in this patient? I will give you a classical example of a head and neck cancer patient. Head and neck cancer is a unique cancer because the organs involved in taste, the organs involved in salivation, chewing, and swallowing all come into play.
Mhm.
Along with that, the patient is in a state of catabolism, what we call as resting energy expenditure. So, if I and you are talking when we are resting, the amount of energy expenditure that is there versus a cancer patient. At rest, the amount of expenditure a cancer patient has is almost double or even triple. So that
Okay.
means the patient is losing energy at every point of time. Along with that, a head and neck cancer patient has a real challenge in eating, chewing, swallowing. And
Mhm.
these patients, they undergo massive surgeries of removing the complete tongue or removing the lower jaw, or we even give radiation so that there is a lot of inflammation happening. So now what the way we do is, one is of course a body weight, which is a very crude way of assessing, because a patient may have an increasing body weight, but still the patient may be having a worsening malnutrition because of fluid accumulation. When there is low albumin or protein in the body weight may increase because of more fluid. Therefore, body weight in itself is not sufficient. We should look for what is known as a lean body weight. And also, we look for inflammatory markers, like what is the pulse rate, what is the albumin. Albumin is an excellent marker for malnutrition. It is a protein synthesized in the liver. And then we have something called C-reactive protein. This also implies the amount of inflammation in the body. The moment there is inflammation, there is catabolism, and there is less making up of the body. So these few parameters will help. And one more I will tell you is the hand grip or the muscle mass. So when I ask the patient to just grip my fingers, has the grip increased over a period of time? In the sense, the energy, the power, the muscle mass has increased over a period of time. So this is the way. So of course, body weight is very good and we usually look into. Along with that, edema, heart rate, and we also look for inflammatory parameters like albumin, CRP, and hand grip, which is a very subtle but extremely important. You cannot have a malnourished patient with a proper hand grip. This patient would have had an inadequate or a suboptimal hand grip. So these are subtle ways. And we monitor these patients on a weekly basis. And let us say the improvement is not happening, or it is less than expected, or there is worsening, then we do something called enteral feeding. Enteral feeding is, we bypass the oral cavity, we put a nasogastric tube, and we feed those patients on regular intervals with proper calories. Naaznin, ma'am, will be able to elucidate how we can modify a diet to feed through a nasogastric tube. But these are the ways, regular mode. So not just diagnosis, assessing what is the reason for malnutrition, periodically assessing for inflammatory markers. Are they coming down? Are they improving? And subtle things like hand muscle grip. So these are the ones that would help me to follow up what is the improvement with my dietary intervention. Thank you.
Very, I would say, on the point and very correct classical educative examples, Dr. Chandrakant. Moving over to Miss Nazneen, I mean, just like Dr. Chandrakant just mentioned and Dr. Purvish mentioned in the past about communication, I'd like to talk a little bit about the collaborative care that oncologists and dietitians provide together for any cancer care. So how do you as a dietitian, and how do this question is also a general open house question to the oncologist here as well, that how do you people in total ensure a very seamless communication, that week by week a dietitian is able to modify the treatment and then obviously provide a holistic care to the cancer patient. So let's talk a little bit about the communication that happens between a nutritionist and an oncologist from a nutritionist's point of view. Over to you, Ms. Nazni.
Okay, that's a very interesting question, Dr. Nishant. I think the seamless communication is very important, right? Because whilst on one hand, the oncologist, of course, is the helm of ensuring that the treatment selected is correct. The nutritionist, on the other hand, actually is firefighting with the patient, with the families. Sometimes there are, budgetary restraints. Sometimes there are psychological restraints wherein the person is just not ready to eat. Sometimes he wants to eat, but he's unable to eat. And so to meet that particular nutritional requirement, okay, which is required, has to, so you can't really step it up on the first day. So this constant dialogue with the oncologist, with the caregivers, with the patient, on how we are going to actually step this up part by part and achieve the target is very important. Yeah, so there is a constant, sometimes even there are psychologists involved, there are social workers involved, wherein this communication also, so there is a big team which you are constantly communicating, and the nutritionist actually is at the helm of all of this. Sometimes there are certain foods which may not be tolerated. In that case, again, the oncologist and the nutritionist need to decide that, okay, this was a food which kind of, triggered a particular thing. A simple thing like nuts. Okay, so it's an anti-inflammatory food. We'll tell the people to eat it. But sometimes if the families have traveled and the nuts have got fungus, it may trigger a bad infection, which kind of actually brings down this entire, puts him in a really bad space. So I think dietary counseling again is very important, but this constant dialogue that every person in the team also reiterates with the same language again is important, so that we are able to kind of, achieve the message that we are. Of course, patients are very careful, but there may be several uncontrolled situations also which happen. So at every stage, communication is important.
Right. So,
Right?
like I said, it's an open house question, and we have heard a nutritionist's point of view about the seamless integration between the two sides here. I'd also like to hear the views on the same collaborative care from Dr. Purvish now. Sir.
Thank you. So earlier, when a patient asked an oncologist, "What can I eat?" the answer would be, "You eat whatever you want." Okay. Then it went on to saying that, look, I am not the expert. I will send you to a nutritionist and they will tell you what to eat."
Mhm.
In both circumstances, the patient is not satisfied. Okay. Patient wants that he should be patiently heard and he should be given a so-called customized solution for what he is requesting. So if we give them a pre-printed handout after the explanation, again they are not satisfied.
Okay.
So in the pre-printed handout, we have to tick and cross things. So then the person feels that yes, now I have got something specific and special for me, and
Mhm.
then they feel satisfied. Earlier, we used to also have some sort of conflict between what we recommended versus what the dietitian recommended. But over the years, I think that thing has been sorted out. Now we are on the same page. They understand what happens when the patient is getting chemotherapy or targeted therapy,
Right.
and we understand how they calculate and give the idea of what is to be treated. Now, Chandrakant mentioned very clearly about head and neck cancer
Mhm.
and how the nutrition has to be modified based on what uh, the patient is going through. But in certain instances, we can anticipate that as soon as the treatment starts in a matter of 1 week or 2 weeks, the patient is going to be totally shut off on taking oral feeds. And this commonly happens when the patient of head and neck cancer is concomitantly, simultaneously getting radiation and chemotherapy. And the ulcers in the mouth, the painful swallowing, and all becomes progressive for 3 to 4 weeks.
Mhm.
Now, what I do is that I show them photographs of what happened to my other patients. And then I tell them, see, you are going to go through this process. And it will definitely happen to you. It will be painful. But remember that no matter how painful it is temporary. It will subside. And after it subsides, you will come back to near normal. But in order to tide over this crisis, instead of waiting for you to become nutritional deficient, we want to
Mhm.
preempt that. And
Right.
then the same tube that Chandrakant was mentioning, either through the nose or into directly into the stomach from the abdominal wall, we put that in beforehand and start building up the nutrition of the patient. So in that instance, even though the pain and inflammation may continue, but the nutritional status of the patient will be at a much higher level. In other words, this is a constant communication. It's a three-way communication. Patient party on the one hand, the oncologist at the other end, and the nutritionist at the third. And if the three of us are on the same page to the satisfaction of the patient party, then things move. Now, here there is one more aspect. We have to understand whether it is the patient who is the decision maker or there is a caregiver on the patient's behalf who is the decision maker. Because if we talk to the other person, then things are not going to come. The
Right.
understanding and getting on board and buying into the whole plan has to be by the person who is going to dictate or who is going to take care of the patient, because he is the one who has to go out into the market, buy the stuff and provide. The patient is not going to go out to get the stuff. So
Hmm.
in other words, I should correct myself. Instead of a three-way communication, we should talk about a four-way communication. And if that happens well, then I think it's the best situation for the patient. Thank you.
Right. Thank you for those insightful words. So, Dr. Chandrakant, your views as well on the collaborative effort, very rightly as said by Dr. Purvish, about between a dietitian, about between an oncologist, between the caregiver and the patient themselves. So, your views on this collaborative effort to enhance the overall treatment journey for an oncology patient. Over to you, please.
So, with time and again, we have understood that care of any patient is a teamwork. You know, the expertise what I have, the other specialty may not have. The other specialty's expertise I may not have. So this has been well replicated in cancer care. You know, for cancer treatment, we have something called multidisciplinary team. Like the patient need not go from one doctor to another doctor. The
Hmm.
patient sees surgeon and then goes to physician and then goes to radiation. So he keeps roaming and wasting time and all that. And a collective thought is not happening. So what we do for cancer care is a multidisciplinary team where we all sit in one room and the patient sits in front of us and we make a plan for them. This is for cancer care. So nowadays, what we are trying to do in our institute is a nutritional MDT, where I sit. If a patient is diabetic, an endocrinologist sits, and then we have a nutritionist who is there in front of us, and a gastro if there is an issue with a pancreas or other, or there is a fatty issue. This is called a nutritional MDT, and this is really working in a good way. So thing is that it's a very initial stage, but this sort of a nutritional MDT where a complex patient needs to be assessed by multiple people is important. So there are multiple instances where I say you can have fruits and the nutritionist says no fruits, and I say you can have sugar and the nutritionist says no sugar. So these sort of uh, discrepancies, when they exist, the patient starts losing trust and he starts hearing to others who say no sugar, sugar is poison, and all this sort of stuff.
Mhm.
So therefore, when a nutritionist and a treating doctor, and whenever required, a gastro or an endocrinologist sits together and makes a plan to the patient, having realistic targets and assessing them, their improvement, I think that is the way to go. So very important coordination among treating doctors, because what expertise I have, the other person may not have. What expertise the other person has, mine may not have. And when you combine these expertises together, then it is a cumulative way of putting in perspective, and the patient gets really reinforced. And a patient is assessed by multiple people together. I think that that's the way it probably
Right.
goes.
And I think winning the patient's faith in any treatment journey by the practicing medical practitioners is also very important. It holds a very important step. So, moving on to post treatment, let's talk a little bit about post treatment nutrition. So, my question will be for Ms. Nazneen here, that for after completing cancer treatment, patients often aim to restore their health and regain normalcy in their life. They'd like to go to the offices and they like to live their life the way that it was maybe before cancer. So, what role do you feel nutrition plays in bringing back the homeostasis and bringing back the normalcy of a patient's life, how it could have been or was a couple of months back? And any specific dietary guidelines, a broader dietary guideline that you would like to showcase? Over to you.
Yeah, thank you, Dr. Nishant. First of all, I must say a big congratulations to Dr. Purvish and Dr. Chandrakant, because what Dr. Chandrakant described was an ideal scenario. Honestly, across a lot of hospitals, this this team coordination doesn't exist. Many a times a dietitian doesn't exist. And I think we need to give a lot of impetus to nutrition there. And this whole team approach is very, very important, where the doctor and the nutritionist are on the same page along with the other team members. So I think great work there, Dr. Chandrakant and Dr. Purvish. You all are like some of the pioneers who are actually integrating so much of nutrition. So thank you for understanding that. Over to your question, Dr. Nishant, is yes, moving on. It's extremely important because here we look at, whilst we definitely want to ensure that all the strength and the vitality is increased, we look at low glycemic index foods, things which are not, so we don't say completely no sugar, but wherever the person can manage on a healthier diet, avoid all the high fat sugar foods. That is one strategy. Two is also we give a lot of impetus to gut health, because here we're looking at inclusion of prebiotic foods, probiotic foods, so that a healthy gut may help in modulating the overall health. The third part is increasing antioxidant food, so that these antioxidant foods act like preventive mechanisms for any future recurrence. Also, anti-inflammatory foods. This is something which we have now, since the patient has already learned across this journey, we encourage him to kind of eat these anti-inflammatory foods. So your nuts, seeds, millets, etc., all these need to be included. Protein definitely is something which we stress on immensely, because as our country as a whole eats a lot of carbs, and our muscle mass is very little. So, and muscle is directly, the sarcopenia is directly related to the ability to fight infection and increase immunity. So that's something which we largely work on, more so with all the vegetarian patients. So we try to kind of teach them on how to distribute the protein every day, include some source of protein at breakfast, lunch, and dinner, not only in one meal. Getting back, we also encourage that they do healthy doses of exercise. One, that it directly helps in muscle building. Some amount of resistance training also helps in muscle building. Sath hi sath, it helps them to uplift their mood. So that's a practice which we make sure that all patients do. Some amount of mindful exercises like yoga, breathing, pranayam also encouraged, so that you're in a positive state of mind, because a lot has gone behind, and it can be traumatic. So along with food, all these suggestions are also given, but essentially we encourage them eat home cooked food. If that's not always an option, then we give them a list of things which they can choose to eat, so that you're not going back to the original cause where things started to trigger.
Right. Very, very educative statements, Ms. Nazneen. So, building on the same, Dr. Chandrakant, I'd like to maybe add a question to what Ms. Nazneen was just talking about. So, how often do you see patients after oncology treatment, the survivors of cancer? How often and how quickly are they able to restore their nutritional health? And I'd also would like to learn your views on the importance that post-treatment nutrition will have in generally bringing the normalcy back for them. Yes, over to you, Dr. Chandrakant.
Yeah. So again, I mean, it's much more relevant, or it is as relevant as during and before treatment. Nutrition is important even after the cancer is over. So what happens is, when the patient is going through cancer and the process of treatment, we would have set them to have a high protein diet, more frequent meals, supplements, all this. So some patients, even after completing the treatment, we have something called RDA, means recommended dietary allowance. This is the amount which we are supposed to take for our optimal health. If you can take less than that, you are malnourished. If you're taking more than that, you are supposed to become obese over a period of time. So you'll be surprised to know those patients who are cured of cancer. I will give you an example of germ cell tumors or testicular tumors or lymphomas. When these patients complete treatment, these patients do not die of cancer, but they die early. And the reason why they die early is because of what is called metabolic syndrome. Metabolic syndrome is obesity, heart disease, diabetes, and so on. So it is well known that cancer patients, after having attained a cure and are into a phase of normal life, they
Mhm.
invariably go in through a phase of metabolic syndrome. you
Mhm.
know so they are more susceptible for heart disease, they're more susceptible for diabetes, and so on. So it's very important for them to follow a strict balanced diet so that they do not get into this vicious circle of metabolic syndrome. Many times what happens is a patient completes treatment for lymphoma with me or leukemia with me, and I would call the patient after 6 months for follow-up, and I'm surprised to know a patient has gained 10 kgs of weight in 6 months. So probably he has overfed or he has rested or whatever, or the cancer has gone away, the treatment insults are gone, but the patient now has got 10 kgs of weight gain in 6 months. And then many times I see that these patients end up having a stroke after some time. So it's very important to be cautious on the nutritional balances in these recovered patients, not just overeating and overfeeding, but you also need to be cautious on the other side. The moment you're cured of cancer, you are at a higher risk of having metabolic syndrome and other problems. So therefore, then they have to go to exercise. So we always motivate these patients for regular physical activity. So
Mhm.
there has been evidences where a patient having regular physical activity versus no activity, they have a higher tolerance to cancer treatment and faster recovery from cancer. So therefore, physical activity for muscle strengthening and preventing metabolic syndrome and testing their thyroid hormones, they're important because thyroid goes for a toss when you give radiation for various reasons. And immunotherapy era, thyroid abnormalities are very common. So I would say that nutrition becomes more challenging, even more challenging after completing treatment for cancer. And we should be very careful about heart disease, diabetes, and so on after having completed cancer treatment.
Thank you. Thank you for, I think, connecting the dots here for us, Dr. Chandrakant. Now, I think moving over to the last segment of our discussion, I'm going to start this with Dr. Purvish. So, I'd like you to give out certain key uh, takeaways from this session and a last takeaway message for all our viewers and everyone who's watching, and your message for the importance of nutrition in oncology care. Over to you, Dr. Purvish.
So, can I just start by adding to the last question first?
Please, please.
See, though while we speak on what is ideal situation, when a patient is completing the cancer directed therapy, there are two things that are uppermost in the patient's mind. One is, thank God my treatment is over. Now I want to go out and party. Okay. So they want to booze, they want to smoke, they want to eat outside food, etc. The second thing that is in their mind is, now I don't want to see the doctor or the hospital ever. You know, these two factors are there which we have to somehow overcome if we want to make sure that the patient will follow up regularly. That is the
Okay.
first. The second thing is to for an oncologist to get the confidence for the patient about non-oncology related day-to-day activities. While the treatment is on, we have to build a rapport by giving them small messages. For instance, if the patient is going to lose hair either because of chemotherapy or radiation therapy, I tell them, see, your hair will come back, but when it comes back, it will not be the same shade of color that you have just now. It
Mhm.
will be thinner and it will be curly instead of being straight. Now, when I've told them in advance before it happens, and then it goes on, and that is exactly what happens, then they suddenly realize that this doctor is my friend. He will be able to give me advice more than just the cancer directed therapies.
Hmm.
The second example I gave them is about how the information about nutrition and its effect on the body is changing all the time. Whatever anybody has advised today may not be the same as it is after a few days. Now, earlier we were thinking that cholesterol in the eggs is bad, and
Hmm.
we should always restrict the amount of cholesterol that a person is taking. Now, the knowledge has shifted. Now, cholesterol is not a nutrient of concern at all. So there is no problem in taking cholesterol. In fact, every cell in the human body is made of a cell wall which contains cholesterol. So if we don't take sufficient cholesterol, we are going to get into deep trouble in all the organs in the body.
Hmm.
So I think again we have to be very practical about this. And the message that I would like to convey to patients at the end is that now we are back to a new normal. Okay. You are never going to be back to a normal which was existed before the diagnosis was done. Because of one is that you have become older. Yeah, there is a normal process of aging. Second is that you have had a major illness, life threatening illness. And third is because it was a major illness, you had major treatment that has pulled you out of this illness.
Correct.
So now, when you go back into life, you are in a new normal and you have to learn, take baby steps first and then, learn to run. And therefore it is vital that every aspect of your day to day activity is monitored and optimized so that you can go back to as near normal as possible.
That's
So
possible.
this is the philosophy that I follow when I give advice at the end of the treatment. Back to you.
Right. Thank you for that insightful message, and obviously the addition to the post-treatment nutrition that we were talking about. Over to Dr. Chandrakant, your message for all the viewers and all the survivors out there, all the patients who are maybe undergoing or are in the stages. Your message to them in context of nutrition, its importance during the treatment, and creating awareness. Over to you, Dr. Chandrakant.
I think I would second what Professor Purvish has said. I think he said exactly what everybody should get. I would just add a few things. Uh, you must take out the fats that you have. You should not take fruits during treatment. This is a fat. This is a myth you should take out from your mind. There are multiple clinical trials which have showed that taking fruits during treatment is not harmful, provided you wash them and eat them properly. And number
Mhm.
two, of course, eating too much sugar is of course harmful, but having up to 6 teaspoons of sugars is not harmful for any patient. Okay. So of course, having a low glycemic food is excellent, but you cannot keep having carbohydrates here and there, but limited amount is of course safe. So we should be very cautious before we buy anything from the media or from someone. Someone says it is harmful to eat fruits, then it's harmful. Then so you need to be very
Right.
cautious before you have a hearsay and you immediately bring into practice. And then you must always consider diet as important as cancer treatment because we are what we eat. So therefore,
Right.
diet should never be ignored. So, and I think it's a message for all of us that diet. Uh, uh, there are some dietary modifications. For example, glutamine. If you have a glutamin rich diet, then these patients would tolerate treatment well and they would have a shorter hospitalization.
Hmm.
So these timely modifications and alterations in the diet planning can happen only when they are in close consultation with the doctor and the dietitian. Therefore, nutrition is not just eating, it is eating medically, which suits your disease, your treatment, and yourself. So you must never ignore it, and you must not buy facts that you hear from anywhere. You need to always check with your doctor what you have heard is true or not. I think this should be the way. Thank you.
Correct. Thank you for your closing remarks for the panel. Over to you, Miss Nazneen. Your last couple key takeaways or the advices that you'd like to give to our viewers and all the patients or the general awareness out there. Over to you.
Okay. I would say nutrition is extremely important from the time you got detected till your treatment modality is over. At every stage, it changes. Okay, so you have to trust your nutritionist and your doctor when they say इस stage पे ये करना है, इस stage पे ये changes है. So at the start of the treatment, the impact is you trying to, build on muscle, reduce the inflammation. During the treatment time, our focus is on, having a protective effect and ensuring that the inflammation is reduced. The nutrition does not interfere with the treatment modalities. It helps in getting better. Post treatment recovery is important. You building up post surgery healing is more important. After that, as when you're on a maintenance diet, again, don't forget nutrition. Eating out once in a while is good. It's good to burn normally, but if you start eating, drinking, smoking like before, it definitely has repercussions, because now you already have a higher risk. So I think that is very important. Also, don't compromise for that little cost of eating better, because it has long term benefits. So people cut corners, I think. And this is not only for cancer survivors, this is for every single person who's watching the show, that when you invest in eating better, it helps you in better healthcare and lesser cost of disease management. So please eat healthy today. Uh, as Indians, we eat too much of refined carbs. Reduce that. Increase your protein content. Eat a whole variety of fruits and vegetables. Include nuts and seeds. Create a dietary diversity. Dietary
Mhm.
diversity means हर टाइप का फूड खाओ. खाली किसी एक क्वैक ने बोला है एक फूड खाओ, डोंट स्टिक ऑन टू दैट, बिकॉज नॉट वन फूड इज मिरेकुलस. You have to eat everything. You have to eat in moderation, balance, exercise well. Only then we can achieve this. So that's my takeaway, that eat healthy and stay fit.
Right. So I thank you, all the panelists. I think the key takeaways that each one of you has summarized during our entire panel says that it is a very collaborative effort from a nutritional side point of view, from a medical oncologist point of view, or let's say surgical or radiationist oncologist point of view, and it's a very multi disciplinary approach. So I really appreciate the time, Dr. Chandrakant, Dr. Purvish and Ms. Nazneen, that you guys have spent in trying to create awareness about nutrition and nutrition's importance in oncology care. Voice of Healthcare thanks you all for being a part of this panel. And I also would like to thank all of the viewers who came across and were a part, were an engagement in this session. Thank you all, and let's try to create more public awareness, more impact on the importance of nutrition on this National Nutrition Week. So thank you.